All righty. Everybody can see my screen okay?
Yes.
Yes.
Thank you very much. Okay. Okay. So this is a Zeopatch recording that I recently reviewed, and I want to know what rhythm you believe this is. I am going to start with Dr. Zawani. What do you think? What's going on here? Tariq, are you still there?
So I think I see a delta wave there.
Say that again. I'm sorry, I missed the last.
I think I see a delta wave.
Delta wave, okay. Is that it? Is that the answer?
Yeah, I believe so. There is a sinus. I see a sinus rhythm, but with yeah, it looks like a delta wave. So WPW.
Okay, so you're suggesting this is WPW. Well, what do you think about the relationship between the P waves and the QRSs on this tracing? Like here's a P wave.
WP.
Here's another one.
Wolff-Parkinson White syndrome.
I understand what WPW is. Thank you. But in WPW, is there a one-to-one relationship between the P waves and the QRSs? When you're in sinus rhythm with WPW, what is the relationship between the P wave and the QRS? Tariq, are you still there?
Yes. Yeah, usually it's not a one-to-one.
I'm not sure I agree with that statement. When you're in sinus rhythm and you have WPW, you are correct that there is a delta wave, but what is the delta wave connecting? What precedes and what follows the delta wave when you're looking at someone with WPW in sinus rhythm? What immediately comes before the delta wave and what is the delta wave followed by?
So what precedes it is the atrial depolarization. So
right. P wave, right?
Yeah.
And what immediately follows the delta wave?
It's the ventricular depolarization.
Correct. So if you're in a sinus rhythm and you have WPW, right, there should be a QRS that follows every single P wave. Do you agree with that statement?
Yes.
Is that what's happening on this tracing?
No, because in many, there is no P waves preceding that. So
that's correct. So is there any kind of consistent relationship you can draw between the P waves and the QRSs in this particular individual?
No, so they're completely dissociated.
So they're completely dissociated. So, when people have WPW, they actually have two possible ways to associate the P waves to the QRSs, right? They have the pathway which will conduct from A to V, and they have their own AV node, which will conduct from A to V. So people with WPW actually have a very close relationship between the P waves and the QRSs. There should always be a QRS after every P wave. In fact, one of the things we do, right, when we're doing an EP study on someone with WPWs, we'll often give adenosine and we'll confirm that there is consistent VA and AV conduction in the setting of adenosine, because we know that most of the time accessory pathways are adenosine insensitive. They don't respond to adenosine. So the relationship between P waves and QRSs in WPW is very, very strong, if you want to think of it that way. So, so there's no relationship on this tracing, right, between the P wave and the QRS. So what would you call this rhythm then? When there's no relationship. It does seem to me, right, that there's almost more QRSs than P waves, right? So I agree with you 100%. There is no relationship between the P waves and the QRSs in this tracing. And like, because here's a P wave, and then we don't see one for a while, and then this T wave maybe has a P wave in it. And then there's a P wave here. And maybe there's a P wave on top of this T wave, hard to know for sure, and then a P wave here. And here we see this P wave is coming after the T wave. Here, maybe there's a P wave before the T wave. So there's complete dissociation. And it appears to me almost like the R to R interval is shorter than the P to P interval almost, right? So when you have a dissociation between the A's and the V's, and you have more V's than A's, there's really only two possibilities for a diagnosis here. Do you know what those might be?
So when the P waves are completely dissociated with the
QRS.
Then with the QRS, then like one possibility could be like third degree AV block.
Correct, right? Absolutely. And that's correct. And that is in fact what we have here is this is a complete heart block.
Okay.
And when there are more V's than A's, what do you think that could be? So the possibilities are, first of all, we can't tell for sure, but I will tell you, this is paced rhythm. This is, every QRS on this tracing is paced. And I think that this little sharp deflection at the beginning of the QRS, which you may have been thinking was a delta wave or the beginning of a delta wave, is not. It's actually just a pacing spike. And so if I told you that this patient has a pacemaker, based on this tracing, does the patient have a single chamber or a dual chamber pacemaker, and which chamber is being paced?
So think dual chamber, and the atria is the one paced.
Okay. Well, actually, no, it's single chamber. If it were dual chamber and somebody has complete heart block, right, you wouldn't pace the atrium because you wouldn't conduct, right? You know what I mean? You understand? If someone has complete heart block, pacing the atrium to raise the atrial rate will do nothing to raise the ventricular rate. And it's the ventricular rate, of course, which controls our cardiac output and cardiac index. So this is actually, and if it were a dual chamber pacemaker, what we would want is we would want A-sense V-paced rhythm, right? Because patients who have complete heart block usually have normal sinus node function. They just have AV nodal block. But in this case, what we have here is V pacing with complete AV dissociation. So this is actually a ventricular pacemaker without an atrial lead. And what's interesting is the atrial rate seems to be slower than the ventricular rate. So this patient also has a little bit of sinus node dysfunction. It's a child who had congenital heart surgery, ended up with complete heart block. and has a ventricular pacemaker. Now, you might be asking, why is it that I even did a recording? There are some centers that do Holters or Zeos on every patient with a pacemaker. I have never been that type of, that's not been testing that I have routinely done. But in this particular patient, there has been some concern that the pacemaker wire may intermittently not capture. And so I did this recording in order to confirm that there was 100% capture at all times, never a non-capture beat. And in fact, that was the case, thankfully, for this patient. So just to summarize, this is an example of complete heart block with VVI pacing. Again, I'll remind you that with the pacemaker code, the first letter is the chamber paced, the second letter is the chamber sensed, and the third letter is the special feature, which in this case would be being inhibited by intrinsic ventricular activity. And so this is a VVI pacemaker in somebody with complete heart block and a little bit of sinus node dysfunction, and it's pacing at a rate of 70. Another interesting observation about this patient was that despite the fact that there was a rate responsive feature on the device, and remember that patients, pacemakers have a rate responsive feature you can turn on, which can detect motion and slowly raise the heart rate, similar to what would be expected from a person's own intrinsic adrenergic tone. And yet, despite the fact that it was on, this patient is paced 100% of the time at a rate of 70, showing that the rate responsive feature on these devices can be very, very insensitive. Now, in her particular case, the device is in her abdomen. And it has been my experience that when the device is in the abdomen, that particularly results in very little rate responsiveness. About a year ago, Josie and I upgraded somebody from an abdominal implant to a transvenous system in the shoulder, and we turned on rate responsiveness, and the patient couldn't stand it because he had never had so much variability in his heart rate before, and he made us turn it off because he couldn't take it. He was so used to having a very stable rhythm without much variability. So this is VVI pacing at a rate of 70 in somebody with complete heart block. And in small children, we routinely will put single chamber devices on. You can put a dual chamber device, but oftentimes single chamber is perfectly adequate. And when they're older, it can be upgraded to a dual chamber system. Okay, let's move on. All right. So this is a tracing from many years ago that I had somewhere in an old file that I found yesterday. And I'm asking you, what is happening in the tracing here? This is at 8:29. Unfortunately, I cut off the time here. This is the 8:29 tracing, and the lower tracing is the 9:59 tracing. And this is the intrinsic rhythm, and this is the intrinsic rhythm with 25 milligrams of adenosine. And the questions I'm asking is, what is happening at this tracing? And would you give adenosine? I see, they were both with adenosine. Would you give adenosine again? So it seems as if at 8:30, they gave adenosine to this rhythm and saw this. And then they repeated it again at about an hour and a half later. So I'm going to ask Chief Fellow, as Perna Bonsall, what she thinks about this tracing and whether she would have, first of all, what's going on here, and then would you have repeated a dose of adenosine here?
Good morning, Dr. Bass.
Good morning.
So, Dr. Bass, if I understand correct, the arrow in the first tracing at 8:29, that's where it indicates the adenosine was given?
Yes, I think so. Although since this tracing is literally 20 years old, I don't really remember, and I don't even know who put that arrow there. But yes, that's fine. Let's assume that's when the adenosine was given. Or somebody thought they saw adenosine effect. I don't know. Whatever.
Okay. Okay, let me just take a look over here.
Take your time. Analysis. Important.
So in the beginning of the tracing, I think there is a P wave just after between QRS and T.
I would agree with that statement.
which sort of seems to land before the QRS, just right at the time of that arrow.
Okay.
And then after that, it's kind of difficult to say if I see the P wave. For the next two, after that, I think it's in the T wave, and then just, I mean, it's difficult to calculate. It says pulse is 143 here. Heart rate is 162.
Yeah, I think the heart rates are exactly the same in both of them. They're both 165. Sorry, this is an old tracing, so you can't see.
No. So I think in this one, what it seems like is probably age. Do you know the age, Dr. Bass? It says adult alarm, so I would consider it.
I think it was a young adult in their early 20s, I think.
Okay. Yeah, so I would call it, it seems like it's a tachycardia, SVT with retrograde P wave based on what I see in the initial few beats, the P waves.
I mean, Perna, you've made an observation that the P wave seems to be changing in regards to its relationship to the QRS. Right here, you said that you noticed this P wave that was between the QRS and the T wave, I believe you said, which I agree. And then you noticed that this P wave right near this random arrow was in a different location in relationship to the QRS. Do you still stand by that comment?
I do.
Then so if there is a change in relationship between the P waves and the QRSs, is that consistent with the diagnosis of SVT?
No, it's not. It's not.
Why is that?
Because then again, it would be like dissociated P waves. This was AV dissociation.
Right. There is no consistent, especially in the setting of adenosine, right? You clearly see, like, look at this P wave here, right? This one is falling. It's between the QRS and the T wave, but it's even at a different location between them than, say, this P wave, right? Right. This P wave is a little closer to the QRS. This P wave is a little farther away from the QRS. So it seems like when adenosine was given, there seems to be dissociation between the V's and the A's. And yet, have you noticed any change in the heart rate from the first half of the tracing to the last half?
Not really. Yeah, not really. No.
So what could you say based on this response to adenosine? So it seems like the heart rate hasn't changed despite giving adenosine. Anything, and it also seems like there is ventricular-atrial dissociation. Now I didn't give you a large enough period of the tracing before the adenosine, but it's pretty clear that in the setting of adenosine, you have VA dissociation, but you have persistence of the ventricular rhythm, right? I mean, the rhythm is not, the R to R interval is not changing, and yet you do see that there is no relationship between the V's and the A's, or at least not a consistent relationship between the V's and the A's. So what would you say that diagnosis is then, if you have that?
I mean, in post-op patients, we see it in JET.
Right, could be JET, absolutely.
Or ventricular tachycardia.
That's right. So that's very, very good. So when you have more V's than A's and you have dissociation from V's to A's, and persistence of the ventricular rhythm despite the administration of adenosine, then by definition, it must be either VT or JET, okay? So did they need to give another 25 milligrams of adenosine an hour and a half later?
No, because again, it didn't really do anything.
Well, would you have expected, based on your analysis of this tracing, would you have expected that giving adenosine would do anything again? No, because this is either JET or VT, right? So we would never. So basically, whoever obtained this tracing allowed the patient to remain in this rhythm for another hour and a half, and then at the end of the hour and a half, gave adenosine again, suggesting that they never understood what rhythm they were taking care of in the first place. And this is important because you really want to run the tracing when you give adenosine to anybody, because sometimes, even if the tachycardia doesn't break, the fact that we saw persistence of the rhythm with ventricular atrial dissociation in the setting of adenosine is a very, very important diagnostic clue, right?
Mm-hmm.
And so if you had seen this, the next step, so now we basically know, how would you distinguish this between VT and jet? So you are absolutely right. Your differential is jet or VT. How would you then distinguish the two? This is not a post-op patient, so you don't have any wires, unfortunately.
Okay. Okay, so I don't even have wires.
No. And in the old days, when Dr. Quagabor was still operating, he rarely placed wires on patients just to make it interesting for the electrophysiologist. So what are you going to do to figure this out? Well, if it were VT, what would the QRS morphology look like?
Yeah, right. QRS morphology would be wider as compared to baseline. So it would compare to your baseline EKG.
Right. So you would get a 12 lead in this rhythm, and you would compare it to a baseline 12 lead.
Mm-hmm.
And this is one of the reasons why I always say that when a patient comes back from the operating room, it's very important in the first few minutes, once the patient is stable and the nurses have done their appropriate assessments and say that they are okay with you screwing with the baby, to get a 12 lead, because you want to have a baseline to compare to the future. It's also one of the reasons why we get a 12 lead in the pre-op evaluation, so that we have a comparison for the future. So let's say that the QRS here is actually not the same as the sinus QRS. Then we would say this is which rhythm, VT or jet?
VTAC.
VTAC, exactly. So what would you do then for that? Patient is awake, says they're feeling their heart racing, and you've made the diagnosis now of VT.
I assume hemodynamically stable because they're feeling.
Well, the only way I can suggest to you that they're stable is the fact that at 8:29 they were in the rhythm and they were still alive at 9:59. So that's
yeah.
So presumably they were stable, which, by the way, is an important point, because people have the misunderstanding that you can be in VT, that if you're in VT, you're basically almost by definition very, very unstable. But in fact, you can be in VT for long periods of time and be relatively stable. Now, I'll be honest in saying if you left this patient in this rhythm long enough, they would become unstable eventually. But the diagnosis of VT does not equal instability necessarily in everybody. But okay, so now you've got your diagnosis. You're feeling pretty good about yourself. You said, well, I'm not going to be that moron who an hour and a half later gave another dose of adenosine because they didn't understand the original response to adenosine. I have my diagnosis. Now, how are you going to treat it, Purna?
Amiodarone.
You can give amiodarone, sure. That's give you 100% credit for that answer. Any other options you could give?
I mean, looks like the patient is admitted, so make sure that the electrolytes are normal for whatever reason the patient is.
Yes, you can check the electrolytes. The old, let me check the electrolyte answer, which we give you credit for, but I will tell you, I'm still waiting for that patient whose electrolytes were so abnormal as to cause this. But yes, that is possible. You know, if the potassium were like 1 or 11, yes, I think that's possible. Or calcium was also 1, but what else? They're all normal. What else would you do? But the amio is good at the answer. I'll accept that.
Procainamide. Could you do procainamide for this?
You could use procainamide, sure. That works well. And then there's a third IV agent that you might consider.
Esmolol.
All right, then there's a fourth. Yes, you could use esmolol, although I would not recommend it for treatment of VT, but I guess it's not. I don't think that would be the right answer, honestly. But you could give lidocaine, right? Lidocaine might work.
Lidocaine, of course. Right? I forgot that. Yes,
So, so those would be the options. And then, of course, you could cardiovert the patient. So that's another option. But if the patient is awake and is stable, you might want to try some of these medical therapies first, since the VT rate isn't very fast. And I'll tell you, the only time I've ever seen patients get into trouble with a tachycardia like this, a VT like this that has been persistent, is when, you know, sometimes when doctors see a patient like this and they're stable, they get the false impression that they can really be very, very slow in managing this. And if you leave somebody like this long enough, another 24 hours or so, they will become very unstable. Also, if someone has already not such great hemodynamics and you leave someone in this rhythm, they may not even tolerate it for a short period of time. So you generally don't want to leave somebody like this for a very long period of time. So very good. Okay, let's move on to the next unknown today. All right, this is a 4-month-old with a very slow heart rate. And I think I'm gonna ask Dr. Grace Kung, your co-chief fellow.
Good morning, Dr. Pass.
Hello, Grace, how are you?
So the lead that caught my eye is V1. I think you can see the atrial tracing the best, and it does look like we have 2 different P-wave morphologies. I am the one that's not as tall, I think, is the sinus, because it does seem to conduct to a QRS and it doesn't seem to be as erratic. And the one that's much taller, it looks like a EAT. That's not being conducted one-to-one, especially in the very beginning you see there. So I think it's intermittent EAT and PACs with EAT that's not being conducted one-to-one. And there is definitely some AV conduction. The heart rate seems irregular with that.
Does this patient have AV conduction disease? I agree with everything you said, by the way. This is a patient with probably has EAT. But do you think this, you know, I also agree that, you know, like this P wave, for example, is not conducted, right? Nor is this one. Is that a sign of the patient having AV nodal disease?
This is a 4-month-old, and that P wave came in when let's see, at a rate of about 150.
Which this one here, you mean?
Yeah, or both the ones that came after.
There's one that came in quite a bit faster, right? Even a rate of 300 beats per minute.
Yes. So that one I wouldn't expect to conduct even with the healthy AV node.
Right.
The second one.
I mean, this one is at like a rate at 250 or so.
Oh, you're right. I was counting from the, yeah. So I don't think it necessarily means the AV node is.
Right. So these PACs are so premature that it would be unfair to besmirch the AV node of this patient because they can't conduct some of them. So what makes this EAT versus multifocal, or sometimes referred to as chaotic atrial rhythm? What is the difference between those two diagnoses?
The shape of the non-sinus P waves seem to be pretty consistent. In multifocal, I think we would expect to see them different.
That's exactly right. That's exactly right. Excellent, Grace. Really good. So this is an example of EAT. So, okay, so the NICU has this patient and they're calling you and they are saying, we don't like this slow heart rate that we're seeing. So what would you do to treat this? So I'll tell you, the patient is already on digoxin and is on 2 milligrams per kilo per day of propranolol. So what would you do if that were the case?
Does the patient have some kind of a line in the atrium?
And that's a good question. No, there are no lines in the atrium. But that would be a good thing, because then you can just pull the line back and assume that maybe it was a traumatic, just catheter-induced ectopy.
The propranolol has room to go up. It could go up on the propranolol.
So the NICU says to you, well, but the heart rate's very slow. Are you sure you want to go up on the propranolol? I agree with that decision, by the way, but how are you going to explain to the NICU why it is that you want to give an agent that can cause bradycardia to somebody who is having an atrial tachycardia?
So I will explain to them that the reason why the ventricular rate is slow is because the atrial rate is so fast that we're not conducting it every beat. And that if we slow down the atrial bit a little bit more, we can hit the like sweet spot where we can have one-to-one conduction and our ventricular rate will be faster.
Right. So there could be what they call concealed conduction into the node on some of these, which is causing slowing. And the sinus rate would come out if all this atrial ectopy at such fast rates would go right. So paradoxically, if we got rid of this fast atrial rate, having a slower atrial rate would result in a faster ventricular rate, right? Because these A's are so fast that they can't actually conduct. So that is correct. So it seems counterintuitive, of course, to give an agent that can cause bradycardia to someone who is having an atrial tachycardia, but in fact, that should help the treatment of this. And then if that were to fail, there's a million other things we could do, but that would be an option. Okay. But thank you very much. Okay, so this is a teenager who has fever and chest pain and cold symptoms. And the computer, this is the 12-lead EKG, and the computer is saying that this rhythm is accelerated junctional rhythm with retrograde conduction. So I'm going to turn to Dr. Sergey Babia of New York City to ask him whether he agrees with this computer's interpretation of this tracing.
Good morning. So heart rate is about 115, and I'm trying to see if there are any P waves before each QRS. And doesn't look like there is a easily recognizable P wave before QRS. Now, accelerated junctional rhythm with retrograde conduction. So in that case, the P waves would be hiding in the T wave. But it's hard to say unless we saw a baseline EKG. On the other hand, the baseline EKG, like whether there is a change in the T wave morphology or not.
Right, yeah, it's hard to tell. I agree with you. If it's not accelerated junctional, so I agree that it is certainly a possibility that this is accelerated junctional with a retrograde P wave that may be buried in the T wave. What else could this be though, Sergey?
So if the P wave is hiding somewhere after the QRS, it could be an AVNRT.
Could be, although this heart rate of 113,
right, too
very,
slow.
very, is quite low for an AVNRT. Even in an old person, it wouldn't be that low.
Well done, you messed up, right?
So it also could be, right, it could be VT, right? We just said that, you know, we have an accelerated ventricular rate. So this could be VT because we don't really know what the patient's QRS looked like before they were in this rhythm. And in fact, the QRS axis is a little abnormal, right? We have essentially an isoelectric QRS and F. So we don't know if this is the patient's normal QRS morphology. And then finally, if there is a P wave in the T wave, it's possible this could even be first degree AV block with a very long PR interval. The patient did have fever and chest pain and cold symptoms. So the question is whether maybe they have like myocarditis with affecting their conduction system. So this actually was the telemetry that was obtained on this patient after being in the unit for a short while. So any new thoughts on this rhythm now that you've gotten a chance to look at this tracing? I'll also, here's another tracing from the same patient.
Yeah, well, now we see that the P waves are, I think it's probably it's a very long PR. Let me just look through it a little bit more attentive. So yeah, it's a heart block.
Right, it's first degree heart block.
First degree heart block.
A very long PR interval. And this tracing was obtained a few hours after this one. And you can see the P wave intermittently coming out even more.
Mm-hmm.
So this is an example of somebody who has a heart block and presumably with a fever and cold symptoms probably has myocarditis. Okay. So interesting tracing, because hard to tell on this one, but all we can say is this is very abnormal. And so when this patient was being evaluated at an outside hospital, the question that was posed to us was, should the patient be transferred to our pediatric floor? And the answer is yes, because this tracing is distinctly abnormal. Normal teenagers should not be walking around in what appears to be a junctional rhythm, but what we really learned from Telly is it was not a junctional rhythm. It was, in fact, a first degree heart block, so which would go more with the diagnosis. And it turns out that the troponin level was elevated in this patient, and they, in fact, did have myocarditis.
Dr. Pass, if you, can you show the EKG again?
Yes.
Would you say these are P waves in lead 3 right after T waves?
It might be. It might be. It's hard to say, right? It's, again, this is why it's always nice to compare to another tracing. But yeah, it sort of looks like there's these little P waves that follow the T waves. Could be. What's interesting is if they are P waves, they're sort of upright, which you would expect if someone were in sinus rhythm. So you would not expect a retrograde P wave to have that morphology.
Yeah.
Yeah. So hard to tell though, because the PR is so long that the T wave has superimposition of the P wave. So, and I think with that we're going to stop for today. Hope everybody has a great week. Thanks for joining. We'll see you same time, same bat channel next week.
Thank you very much.
Bye bye.